to thank everyone for joining our first session at the East Venture Summit today on healthcare. So just to introduce myself, my name is Ari Jahja. I'm the head of Indonesia research at Macquarie and also an healthcare analyst, and I'll be your moderator today. So first, also thank you for East Ventures for organizing this panel session dedicated to healthcare. And we have our distinguished speakers here who have basically committed their lives to also improve patient lives. And then in terms of the how we see the investment thesis for healthcare, Pak Beges, Pak Budi already elaborated earlier about how appealing that the investments outlook in healthcare would be in the coming years. And I actually, as an equity market strategist, I also agree. I do have healthcare as among my preferred sectors in Indonesia due to the near-term growth opportunities, but also the medium to long-term structural improvements. So if you look at the Indonesian healthcare, it has gone a long way. In the past decade, it has strengthened their access to funding as well, and then through the successful rollout of the BPJS Kesehatan, or the universal healthcare, and actually the successful reforms that will be basically implemented through the omnibus law that we're gonna see in the coming years. And meanwhile, just moving to the panel discussion, also just a sponsor's message from East Ventures. East Ventures has been committed to the healthcare sector in Indonesia. Throughout COVID, they have deployed substantial resources to fight against COVID-19, including testing and other measures as well, and also has basically functioned as a bridge between the private sector funding and the public side. So basically, if we look at the thematic, right, beyond the COVID-19, really, what's next that we should be watching out for? The answer is something that actually affects about 74% of deaths per annum, according to the World Health Organization data. What is that? That is actually the non-communicable diseases, which includes things like heart disease, stroke, cancer, diabetes, and chronic lung diseases. And here with us in the panel are the East Ventures portfolio companies who are basically embarking in the efforts to provide solutions that are innovative in the area of chronic disease management. So we have Nalagenetics, also we have MASH-Bio and Aevice with us today. And on top of that, we also have Professor Dante, who's going to be providing us color from the Ministry of Health and how the regulatory framework has been supportive to this through the innovations that have been coming through in the past few years. So yeah, welcome to all the speakers. And without further ado, we're going to kick off the discussions here. And I think we can start from Levy on the right-hand side. Maybe to each speaker, I'm going to ask everyone to introduce themselves, the company, what they do, and also how the role that the company is playing in chronic disease management.
Sure.
Thank you.
Thank you so much, Ari. Wonderful to be here. My name is Levy. I'm the co-founder and CEO for Nalagenetics. Nalagenetics is a predictive genetic testing company that focuses on developing combined risk scoring for cardiovascular, metabolic, cancer, and neurodegenerative conditions. Instead of looking at 2% of the human genome, which is what other genetic testing companies generally do, or even less, we look at 60 to 70% of the human genome and consider health risks such that we are more accurate for diverse populations. So far, for our testing in cardiovascular, we are able to identify 3 times more patients compared to traditional risk factors, as well as for breast cancer, we're able to identify 10 times more individuals who are high risk compared to traditional genetic testing measures as well. So thank you so much. Happy to be here.
Yep. Good morning, everyone. Great to be here. Great to see you again, Prof. Dante. I'm Andrew, co-founder and CEO of MASH-Bio. We're a digital health company focused on analytics and is committed to delivering a future of healthcare that is both personalized and preventive. Our focus has been on developing a scalable intelligence platform that leverages all the multidimensional data that is fully at our disposal today, but not truly being utilized for preventive, personalized patient care. Our starting point and where we've really been very privileged to help serve Indonesia is in the preventive medical checkups, right? By enabling earlier detection, earlier risk prediction, and more personalized downstream patient care as part of the patient journey. On top of that, we continue to invest in research, and we have developed the world's first clinically approved digital twin technology that predicts diabetes patients that will eventually go on to get chronic kidney disease, and which we can delve on a little bit more later. So we're really excited here today to talk about the opportunities in healthcare, right, and how technologies can play a part.
So, hi everyone. My name is Adrian, CEO and co-founder of Aevice. I want to start off by saying that it's a privilege to be here today with the esteemed panelists as well as all the guests over here. So Aevice is a company that develops smart wearable stethoscope. This is actually a stethoscope that you see over here for patients with respiratory disease. The idea started because I basically was an asthma patient when I was very young. There were many times when I found myself having attacks, having to rush to the hospital in the middle of the night. And then during the whole entire care continuum, I have to keep going back to the specialist clinics or GP thereafter for doctors to actually listen to my lungs. So one day I thought, why not we develop a wearable stethoscope that accompany the patients when they leave homes so that we can continue to monitor them at home. And doctors can then, at the comfort of their office, decide whether the patients are getting better or not. And that way we can actually reduce the time required for patients to go back to the hospitals or clinics and potentially also avoid readmissions risks for these patients because of an uncontrolled attack. Our starting point today is asthma, as well as chronic obstructive pulmonary disease, COPD. And we are in the Singapore-US market, starting to go into Japan as well. So I'm very excited to actually be involved in this discussion and share more today. Thank you.
Yes, good morning, everyone. It is a great honor for me to stand up with you here as the Vice Minister of Health, Republic of Indonesia. My name is Dante Saksono Harbuwono. I'm the Professor of Endocrinology and Metabolisms. My expertise is talk about diabetes and metabolisms. But in my role as Vice Minister, I am committed to continue the progress in combating communicable, non-communicable, and new emerging disease, enhancing health infrastructure, ensuring equitable access to quality health care for everybody in Indonesia's citizens. Our current priorities, including strengthening our resource to implement the health transformation agenda. This is very important agenda that we are carrying on right now because we believe the health transformation agenda will be provide equal access to health care services throughout the country and ensuring high quality and healthcare service in each district and province. As a result, we can create a healthier Indonesia by ensuring that people stay healthy, and once they come back sick, they can get advanced health care services nearby or within the city they live. All the achieve of golden Indonesian era in 2045 is not far from now. And to achieve this ambition goal, we can work together. Collaboration and innovation are key to achieve our health goal. I look forward to working closely with our health professional, community, leaders, private sectors to build healthier Indonesia. Together we can create the future wherever every individual has opportunity to lead healthy and fulfilling life. Thank you.
Thank you all, to all the panelists for the overview. So let me just kick off also with the question for Professor Dante, right? As we think about these chronic diseases, can you elaborate the framework that the Minister of Health has to basically tackle these emerging silent killers?
Yes, because we already have the data and research that previously we have the emphasis of our priority is infection disease, so very long time ago. But now the more prominent of the disease is non-communicable disease. It's very important. You can imagine the prevalence of diabetes in Indonesia is 1 of 10 people in Indonesia is diabetes. In Jakarta, it's very more terrible. We have 1 of 8 people in Jakarta is diabetes. Just on diabetes. Another thing is obesity. Obesity is most important because diabetes is caused by insulin resistance caused by obesity. And you know what the prevalence of obesity? The obesity is 1 of 3 people in Jakarta will have obesity. So this is a big opportunity to you to invest in some area in obesity. And you know how many people will die in stroke? 300,000 people every years will die by stroke, and for 250,000 people will die by cardiovascular events. So you can imagine I agree with Ari, it's about the non-communicable disease is one of the challenges to have investment in Indonesian healthcare.
Thank you, Professor Dante, for the color there. Now we're going to move towards the room to basically get a better sense about how innovative solutions that each has in order to address this huge disease burden and probably help to reduce the cost over time. So maybe we can kick off with Adrian, and then we go through the others as well.
So I think maybe I can just share a little bit about the disease that we're focusing. One of the diseases that we're looking at is this condition called chronic obstructive pulmonary disease, or COPD in short. It is basically a disease that is non-curable, where the lungs get compromised and the ability to actually intake oxygens actually reduces over time. The most leading cause of COPD are actually two of the main common causes are smoking, as well as people who are living in highly polluted environment. So the prevalence in the countries like US, and I did a check in Indonesia, is about 3 to 4%. So it's about 3 in 300 people actually got these conditions over here. Without any treatment, a severe COPD patients have a lifespan about 5 years before they pass on. The average spending, again, this is a statistics that we got out from countries like where we are actually at right now. As a whole entire country, it's about $170 billion. Average spending per patient is about $4,000 per patient per year. And the causes of the main bulk of causes that the main bulk of costs that is attributed to COPD are number 1, readmission, hospital readmission. Number 2, medications. And then if you look at the 30 days readmission rate for COPD patients, it's approximately about 24% or 25%. So 1 in 4 patients who are admitted to the hospital today because of a COPD attack end up going back to the healthcare system again, or the hospitals again, within 30 days, 1 in 4. In this optics, what Aevice MD is trying to do here is that are we able to, again, when patients leave the hospital today, they bring this device back home. We have doctors to monitor their conditions. If their conditions are getting worse off, can we intervene early? And what are the interventions are we looking at? We are looking at, can we actually have a nurse having a call with them to counsel them, to actually educate them? What are the best practices to reduce exacerbation? Can we increase the dosage of the treatment? And in this case, patients are looking at steroids, inhaled steroids, oxygen therapy, so that if we're able to manage them, we can actually reduce this admission. But one of the things that is also overlooked very often is not just about the direct medical costs, it's also the indirect costs and burden of COPD, which is when patients like them actually are in severe conditions and they get readmitted to the hospital, they also lose time from work. And this is where the entire burden falls not just on the cost of medical care that they pay for, but it's also about their income. They actually get affected. So in this manner, this is exactly what our solutions here is trying to solve over the long term.
Yeah, thank you, Pak Dante, for highlighting the challenges around diabetes. And in fact, global statistics is that 40% of diabetics will eventually go on to get kidney disease, right? Now, the problem with this silent killer is that the current detection technologies, literally, detection means seeing protein in your urine. By the time a patient has protein in your urine, it's already too late, right? The kidneys are already in very bad shape, and it's very difficult to change the trajectory. At the same time, Many of these patients eventually progress on to end-stage kidney failure, requiring multiple weekly sessions of dialysis, 3 hours being hooked up to a machine, washing your blood. The burden on these individuals who are no longer able to effectively contribute to the economic workforce, right? The burden to their communities is tremendous, especially in a nation like Indonesia, which with as Pak Budi shared earlier, the aspirations of growing the national GDP here in Indonesia. Now, Mesh Bio has been focused on solving this problem. We have collaborated across multiple institutions in Singapore, and as mentioned, we have now developed the world's first clinically validated digital twin, and also with regulatory approval. So what does our digital twin do? We model what's happening in the patient's biology, in the patient's health state, using all the clinical data that's at our disposal. And ultimately, we want to answer the question, will this patient eventually go on to get chronic kidney disease before protein turns up in the urine, right? And we're able to do this with 86% accuracy, one of the actually the highest in the world, up to 3 years before this event happens. How does this help? With this stratification approach, identifying these high-risk individuals, doctors can be more empowered to identify these high-risk individuals and focus care, right? Because as healthcare costs increase, as Indonesia faces the challenges of addressing the broad rise of chronic diseases, how do we best utilize the doctors that we have within the ecosystem, within the community, best utilize the tools, the diagnostics, the therapeutics in this community to focus on these high-risk patients, and ultimately what we want to achieve is to bend this curve on the scourge of chronic kidney disease that we are, not just Indonesia, but the world is facing today.
Awesome. For us, maybe I'll share a little bit more about why we focused on genetics. So genetics can branch off into many different diseases. We chose cancer, cardiometabolic, and neurodegenerative conditions because those conditions are complex. Not only are they complex, they are very commonly seen even in developing markets or markets like Indonesia. Unlike maybe in the US, where genetic testing is very much focused on rare conditions, where reimbursements are strong. But in playing volume, and in a completely new kind of expertise, Nalagenetics has invested in 3 major platforms in Indonesia, which is number 1, research and development. There is still so much to understand about the structural variations, the type of variations that we are seeing for these type of conditions in Asia. The majority of the biomarkers are still based on Caucasian data sets even until today. The second one is investing on market access programs, which means that nobody wakes up to suddenly want a genetic test, right? But actually, people wake up wanting to lower cholesterol. They want to figure out if they want to work out today. These are programs where genetic testing can be a very important and interesting value proposition to why they need to be the one who take care of their disease and how exactly to prevent it earlier. And with this program, we're able to get it reimbursed by insurance companies, embedded into life, healthcare, and group insurances programs today. And finally, the third platform is actually the software itself, where we actually work with labs directly who already have market access programs in different markets, so we can expand what we've learned in Singapore, in Indonesia, in markets like India and Taiwan and other markets as well. So these 3 platforms for us is very important because we've chosen genetics which is maybe a new value proposition, a new expertise that we have to build in the long term for Indonesia and for other markets that we're developing in. So we're very excited to build on these 3 platforms moving forward, especially for cardiometabolic conditions like Prof. Dante mentioned.
Okay, great. Yeah, thank you, Adrian, Andrew, and Levy for providing more color there. Great to see the encouraging developments and in these innovative solutions and how that can improve patient lives. So basically, after hearing these, Professor Dante, how do you see the role of Minister of Health kind of in terms of regulatory framework in order to support these innovations?
Yes, actually, I will emphasize about the NCD that Ari already mentioned. The NCD is very important in our priority now because the population in our community is already changed, uh, become the older population in our population. So this is very important. The NCD is very important to highlight in this issue. And we already have some regulation about that in Ministry of Health to strengthening the priority of that. We already have currently working in 6 pillars of health in Ministry of Health. That 6 pillars are the primary care transformations. The primary care transformation, the primary secondary prevention, improving capacity of primary care in around Indonesia. We have about 10,000 primary health care in Indonesia. So it is very huge number of Indonesia. And also secondary care transformation. In the secondary transformation, we will improve the access quality secondary tertiary care of medication in the people with NCD population. And the third one is a health system resilience and transformation. You know, in the pandemic of COVID, we are difficult to find the people who can have capability to help us. So that's why we should have the health system resiliency. We also lack about the lack of the source of medication at the pandemic of COVID. Learn about the pandemic of COVID. We try to change our priority to make ourselves have our resiliency. Nowadays, we have 90% of the source of material for the medication is still from imported. So it will be more challenge that if you can invest in the 90% of the source of medication will be not imported from Indonesia, it will be great. This is the third transformation. And the fourth transformation, the health financing transformation, you know, we already covers more than 90% of population in the primary health in healthcare, and health talent transformation is the other transformation, and the last one is health technology transformation. Develop and utilization of technology, digitization, and biotechnology in the health sectors is very important. Digital information technology and biotechnology is our priority in the near future to highlight the issue of Indonesia health right now.
Thank you, Professor Dante, for the very useful color there, and good to see potential further strengthening between the public and private partnership. So speaking of which, the next question that I have also for the panel here today is, how do you see the kind of the business model and how to balance out between the private and also the public side in terms of and how to path towards reimbursement? So I'll start with Aevice.
Yeah, thanks a lot. Again, to start off, I think because we have been starting off in Singapore market, before we move into the US market, increasingly we're looking at Japan market, Southeast Asia market, Indonesia market as a whole. We realize that each of this country has its own unique sets of policies when it comes to healthcare. Maybe let me touch a little bit on about the US market first. In the US market, most employees who are working with an employer are insured by the companies. So you have your private insurance, and private insurance will be companies like, you talk about Blue Shield, Blue Cross, you talk about United Health and equivalent. When you see a doctor today, these are the private insurance who will come in to actually pay off for your medical expenses. The hospitals will not bill the patients directly. They will work directly with the private payers to actually, the private insurance company to tap into this reimbursement. And for those who doesn't have work, right, or you are self-employed, then you may have this thing called the Medicare, which is the government insurance. They also do cover your medical care. And for those who are not employed, unemployed, or probably living with comorbidities or disability, you have this thing called the Medicaid, which is reserved for those who are unable to work and a low poverty cycle. So when you see a doctor today, these are different kind of level that actually helps. Americans do not believe in the country itself, they don't buy their insurance. But when you look into Singapore itself, where we are at, majority of Singaporeans, you basically buy your own private insurance on top of government subsidies, on top of your mandatory, we call it national pension scheme. So it's very different. So as a business model, where our company actually works, we have to adapt our solutions, we have to adapt our model based on what the country is, and how it works. So in the US, our model is we work directly with the hospital, we service the hospitals as our customers, and we help the hospitals to get reimbursement for the payers. But with that in mind, what we need to do is how do we incentivize the payers to want to work with us? Our goal is very simple. We try to reduce readmission, we try to improve management of disease, and overall, we help payers to save money. So for that sense, it becomes a business model for us. Hospital will then pay our solutions to help to ensure that patients does not come back to the hospital, and the payers will be happy to actually pay for them. Now, then there come questions. Hey, hospital, do they not want to see more patients because that's how they make more money, right? If I'm going to make a patients come back less to the hospital, then effectively we are taking away their businesses. True and not true. In the US, it's interesting because there are two things that's happening. Number one, when you talk about conditions like asthma, we call it as long-term chronic, low-margin disease. If patients were to come back, it occupies the hospital beds. And this allows the hospitals to actually see more acute cases because it takes up their capacity. At the same time, when I mentioned earlier on just now conditions like chronic obstructive pulmonary disease, COPD, the readmission rate is about 24%. If patient does come back to the hospital has to render the care for them without able to tap onto any reimbursement. So I think this is where we actually adapt our business model according to where the markets are. Yeah, sorry, I think the time is up. Yeah.
Okay. Pari, sorry, I have to interject. Probably you have 3 minutes to wrap up. Yeah, go ahead.
So can we go to the other?
3 minutes maximum.
Yeah,
Go ahead.
please.
I'll keep it short. So I think 2 principles, right? How do hospitals and healthcare providers see value? And we align our pricing models that deliver value for both patients, insurers, and hospitals. I think we have the benefit that we are truly a cloud-based SaaS platform, which means that we have a lot of room for us to both scale and also align our value capture and of course profit, gross profits for investors, because ultimately no system, no technology can truly benefit society, can truly benefit mankind without being sustainable. So being able to scale with sustainability, with decent margins that can contribute to the long-term growth of any technology to impact patient care.
Yeah, I agree with everything. I think the business model around prevention is still unclear in many markets, including Indonesia. For us, we're running 3 experiments or 3 business models, and we'll decide at one point which one is the best. But for now, it's business models around research and development, where we develop and we co-develop algorithms and adjust algorithms based on different countries' genomics. So that's number 1. Number 2 is we're selling the services to doctors and insurance companies. The value proposition there is similar to the others, where we show cost effectiveness. We prevent before things get worse and more expensive. And then the third one is selling just the software, where these markets are already so mature, we'll just sell the software and they'll figure out how to sell it. These 3 things are running in parallel, but we'll see how it evolves over time and the funding landscape as well. So we'll adjust.
Thank you. Appreciate the color there.
Okay, thank you so much. Can we have a big round of applause for Mr. Ari, all speakers? We definitely learned a lot from you from this discussion. Kindly stay on stage. We invite the representative of East Ventures to come up on stage and present this token of appreciation. Once again, all speakers, we would like you and the moderator to stand up. In the coming decade, we believe the integration of technology into healthcare is expected to present an array of significant opportunities for Southeast Asia. Very well. Can we have a big round of applause? We just finished our first session here in Empathy Room. Thank you so much, Pak Ari. for leading the discussion, and also Professor Dante, thank you so much for coming, for sharing your insight today.